Good day. I want to talk to you about schizophrenia today, which is a severe condition we know in mental health. So I think the most important thing to know about it is how to detect early signs and symptoms of the condition and what are the appropriate ways to assess patients for early signs and symptoms and what can be done, what can we do about the treatment and helping people developing a condition like schizophrenia. When we talk about schizophrenia, we talk about a combination of symptoms which are classified as positive or negative symptoms, and more recently cognitive symptoms. Psychotic symptoms, we see the positive symptoms are usually hallucinations and delusions, whereas the negative symptoms, social withdrawal, volition, anhedonia. There's also some cognitive decline, what we see, but also the way they're thinking. The thinking can be disordered. Now, when we're talking about this condition, it is important to understand that the onset of the condition is very early on, mostly in adolescence. So that makes it very important to identify the early signs of emerging schizophrenia. Now, this can be quite tricky in terms of what are early indicators of the condition. Unfortunately, not very specific. What we usually see is functional decline. So, for instance, when we're talking about adolescents, these are kids usually at school, and they develop some unspecific signs that something is going downhill. So, let's say school performance, academic performance is declining, they are socially withdrawing, they show anxiety symptoms, maybe depression symptoms. So, these are all symptoms identifiable as a mood disorder, like generalized anxiety disorder or major depressive disorder. But there can be an early sign of a person developing a more severe condition like schizophrenia or psychotic illness. Now, the issue there is when we say it's not specific, there are other signs and symptoms which probably indicate that this young person is on the way of developing a psychotic illness. So a very brief episode of maybe hearing a voice, maybe for a couple of days, it disappears, is in fact, in combination with the other symptoms, an early sign that this person is at risk of developing a condition like schizophrenia. So I just want to summarize some of the general non-specific signs and symptoms. So we see concentration, attention impairment, reduced drive, depressed mood, anxiety symptoms, sleep disturbance, social withdrawal, and declining interest in people, activities, and self-care. What we see is from clinical studies that we can identify people at risk of developing the condition. However, this doesn't mean that every person meeting at-risk criteria is actually developing schizophrenia. However, they have problems. So we target all these symptoms and identifying people early, which means that we have an early intervention happening. A person who is showing only mild symptoms, you can help with psychoeducation, you can help with CBT, so cognitive behavior therapy. You can target some of the symptoms the patient's experiencing with antidepressant medication to address anxiety and mood symptoms. And maybe you need a little bit of antipsychotic medication, but the doses are lower and also the duration of treatment is shorter. Now, there are a couple of other things. When we're talking about adolescence, there is, of course, one important issue when we talk about developing psychosis is substance use. The most common drug used by young people in our society, in Australia in particular, is marijuana. If we think about marijuana as a drug which is available many thousand years, we have to understand that nowadays the drug available on the streets is different to the one which maybe has been used in the 70s, 60s, 70s last century. It is highly enriched with THC. THC is actually the most potent part of the drug which creates at least a transient state of psychotic symptoms, so people might experience paranoia or even develop hallucinations acutely when they are intoxicated. Now, this content has significantly increased in hydroponically grown marijuana. Now, the interesting thing is there's another compound in marijuana, which is the CBD cannabidiol, which has actually antipsychotic properties. So in the old days, in the hippie culture, if you like, people used the bush variety of marijuana, which had also, if you like, a medication on board, which was helping to alleviate the psychotropic potency of the THC. Now this has changed, and there are quite a few studies indicating that young people who start early using cannabis are more likely to develop a psychotic illness later on in life. Also, it brings forward the onset of the condition as well as the severity. It is generally difficult to treat mental illness if there's also a substance use disorder in the background, because the one condition feeds into the other. And it is very difficult if you target the substance use disorder and leave out the other condition which is caused by the substance use, which can be depression, can be anxiety, can be psychosis. So this is a risk factor. There are other risk factors that need to be taken in consideration when we assess young people. A trauma history, so when we see domestic violence, sexual abuse, general child maltreatment increases the risk not only for schizophrenia but also for mood disorders like depression. Other issues is a family history of a psychotic illness. For instance, if first-degree relative has been confirmed for schizophrenia, the individual risk is increasing by tenfold. That sounds a lot, but think about that in the general population. You have about a general risk of a little bit less than 1% of people developing a psychotic illness, but increases by tenfold, you're by 10%. So, in other words, you need to have 10 children. And if you turn the statistics around, that would mean that most of the people with schizophrenia don't have a family history. If you combine, for instance, out-of-character behaviors, a sudden onset of those, the more non-specific signs, and there is also a family history with a psychotic illness, that increases the individual risk. Now, you as general practitioner will see a lot of young people maybe present with anxiety symptoms, depression symptoms. So what can you do in order to assess their risk further for a condition like a psychotic illness? The best way to do this is doing a normal mental health assessment. That means looking for mood symptoms, observing affect, is it appropriate, inappropriate, assess anxiety for anxiety symptoms. Of course, a substance use assessment needs to be done. Also risk assessment, so that means when we're talking about depression symptoms, is a young person perhaps thinking about harming themselves? So talking about suicidal ideation, then this is clearly an indication that the person needs to be referred to a specialist, or even refer this person to a specialised hospital, a psychiatric hospital, for assessment. So what are useful screening questions you might use? For instance, do you have jumbled thoughts, confusion? Do you feel something's not quite right? Does it sound like your ears, eyes, mind are playing tricks on you? You seem to be fearful to no good reason, with a decline in interest in people, activities and self-care. So these are some of the screening questions you might use to identify someone at risk of developing a psychotic illness. So we have the combination of non-specific symptoms, functional decline, family history, maybe brief non-specific episode of psychotic phenomena, like maybe hearing a little bit of like a voice, or maybe my name is called out, some paranoia, some suspiciousness. This is all together an indication that there is a little bit more happening than just generalized anxiety disorder, or a mild form of depression, or an adjustment disorder. So if you think about the combination of, just as said before, it's really important to think about a more specific intervention. So what could be a specific intervention from a GP's point of practice? Finding a good clinical psychologist with some expertise in working with young people is the first thing. But also think about other services now being available and accessible, like Headspace. or other specialised youth mental health services, or the child and adolescent mental health services, which often have early psychosis programs. They have the experts who can assess these people, but also providing intervention which is more specific. A multidisciplinary team is good because I think also equally important is to involve the family. We know that the better the family support, the better the outcome. Coming back to substance use, this is crucial. Psychoeducation needs to be provided in terms of the substance use disorder. As I said before, the most common one is cannabis, and very often I think it's a good approach to ask the young person, what is it? What is the benefit when you smoke pot? And very often you hear, it relaxes me, it helps me to sleep. So by talking about what is the benefit, you find a way to the young person to explore alternative strategies. So if it's a sleep issue, there are certain medications which can be provided. For instance, quetiapine or Seroquel, which is commonly used to help young people who have anxiety or sleep onset problems. It's a non-addictive drug, it's an antipsychotic. But we are usually prescribing it at a relatively low dose. So when we talk about antipsychotic treatment, we go up to 400, 600 milligrams a day. If we treat sleep problems in this context, we're helping the person not to smoke pot prior to going to bed. We talk about maybe 25, 50 milligrams of this drug. So we help you with prescription medication so that you can stop your self-medication. Now, I spoke about identifying a person at risk. I think it's also important to understand that there's another term what's being commonly used in the context of a psychotic illness. The term I'm referring to is prodrome. Now, a prodrome is by definition only identifiable retrospectively. This is when a person has already developed schizophrenia and diagnosis has been confirmed. Then you can speak retrospectively if you have this combination of symptoms that can be called a prodrome. Now let's talk a little bit about, because you will also see patients who have been diagnosed with schizophrenia, and you are at least partially managing those patients who are doing relatively well on antipsychotic medication. Very often you can achieve a lot. I would say that about 1/3 of the patients we see who have a severe psychotic episode, at least once in their time, make a full recovery. Very often we make the mistake to take them off the medication, the antipsychotic medication, too early. Studies indicate that if you do this, the risk of relapse increases substantially. So as a rule of thumb, we would suggest at least being 2 years of antipsychotic medication, even though the patient is not presenting with any psychotic symptoms. Now, there's another third of patients who will have relapses, even if they are compliant with their medication treatment or compliant with other therapeutic measures. Still, they can have a good quality of life, but they need access to ongoing services to help them, let's say, with occupational assistance, to ease back into some form of profession. A job where they have a high exposure to stress is not very helpful for them to function. Maybe reassessing their ability to work. That doesn't mean they have a complete disability in terms of not being able to work, but we have to find something functioning in an occupational environment. They might need ongoing psychological assistance, so dealing with stresses, so what is the best way to avoid stressful situations, how they can access other services to help them. Again, psychoeducation is very important. Now let's talk about a group of patients, probably 1/3, who, despite the best effort, showing ongoing chronic symptoms of a psychotic disorder, and particularly negative symptoms and cognitive symptoms. So these are the ones that need ongoing care. Most of those, they need access to disability services. Commonly, they need assisted accommodation. They need access to social work services and other services to help them through their daily life. Having said that, I think there's a lot of stigma when we're talking about schizophrenia. But I would say that 95% of patients have a good quality of life if you provide the best possible services. That early intervention is quite effective in terms of alleviating the symptoms and even can lead to full recovery.
It's my distinct honour to introduce today Professor Ulrich Schall, who is an internationally recognised researcher in neuroimaging and in terms of electrophysiological markers in relation to schizophrenia. He has well over 30 years of experience teaching and working clinically throughout Australia as well as in Germany. So welcome, Ollie. It's good to see you today.
Yeah, nice introduction, thank you.
It's a pleasure. So today we are going to be talking a little bit about psychosis and schizophrenia, and I was hoping we could first start off by talking about what it's like when you first meet somebody who may have some prodromal symptoms of schizophrenia and what you should be looking for.
Yeah, it's a difficult area to pinpoint what is actually prodromal, and I think when we call something prodromal, it's mostly retrospectively. Yeah. Once a diagnosis is made of a major psychotic disorder like schizophrenia, we talk about high-risk presentation. So it's a combination of symptoms like functional decline, social withdrawal, mood symptoms, anxiety, but also out-of-character behaviors can emerge. Yeah. We can't see if someone is hallucinating, obviously, or having delusions, but sometimes you can see that the person is talking about stuff that doesn't make really sense. Yeah? They are believing that people are plotting against them or becoming delusional about other things in their life, that maybe a neighbor is there and sending whatever radiation to them, and so really things you start wondering, what's going on there? Yeah. There is an overlap, obviously, that people come with these kind of functional declines, so as for instance not attending school anymore when we talk about younger people. And they're not performing well when they are in an occupational setting, yeah, or training setting. They withdraw socially. Think about paranoia. Yeah, so maybe consider other people as maybe plotting against them, or planning harmful things. So coming back to your question, after my long answer. It depends really what is triggering a referral to a GP, or that when a patient is presenting at a GP practice. It could be just not feeling right, and it's quite a broad. Something is not quite right. That can be one presentation. Reason. Other reasons can most likely are that other people are picking that up, mostly parents, for instance. The child is different all of a sudden, out of character. Philosophy plays an important role. It doesn't make sense what the person is actually saying there. Concerning things like social withdrawal, being in the room. Might be picking up that this person is talking on his own, so might be responding to voices the person is hearing, communicating with these voices. So it's all sorts of things. It's very hard to say it's one thing, but what we usually say is the functional decline, which is happening maybe over a period of 6 to 12 months, which is already concerning. Can be depression, can be other reasons, substance use. There's a lot of reasons that can trigger that. But that's a starting point where we should explore a little bit further what's going on.
Okay. And so, are there specific features that you look for in delineating, say, a depressive disorder from a primary psychotic disorder?
Good that you asked this. We did a large study here in Newcastle a couple of years ago where we had a look at a cohort of more than 100 kids or young people aged between 15 and 21, presenting with these kind of symptoms, not really very specific symptoms at the end of the day, but meeting what we consider as high-risk criteria for developing a disorder like schizophrenia. And interestingly, when we had a look at their profiles and how they present, it was very interesting to see that a lot of these kids actually improved. Most of them also met criteria for major depressive disorder, anxiety disorder, like social anxiety plays a role there, or substance use is quite common. And we had a control group, age-matched kids. Of course, we excluded those not meeting at-risk criteria or having a mental illness, psychotic illness or bipolar affective disorder. And of course, their level of substance use was much lower. So we had about 40% using cannabis in the ultra-high risk group, and it was about 5 to 10% in the control group. So they were not absolutely clean, so the prevalence is high. And also in the ultra-high risk group, about a third were on antidepressant medication, so already targeting some of the symptoms. As I said before, it's at risk. We can't see it's prodromal. We can only say that retrospectively if they really transition to a full-blown psychotic illness, into a full-blown psychotic illness.
Okay, and so why do you think it is that Australia and the US, but we think Pat McGorry and McGlashan, that they were the people who pioneered the early psychosis movement. So fundamentally that then transited to understanding that there's an at-risk mental state. And I guess I'm asking you because oftentimes when a young person will walk into a GP's practice, they'll feel pressure to make a diagnosis. So what advice would you give to them?
Look, I mean, a diagnosis is, of course, helping you to make a decision about what needs to be done for treatment. We did another study where we used specialised CBT intervention, which was designed around kids presenting with these kind of spectrum of symptoms. And there was 5-6 sessions how to deal with unwanted ideas, maybe challenging delusional thought content, but also standard CBT stuff, targeting depression and anxiety symptoms, but also looking into substance use issues. So it's more catered around a couple of things where we try to address some of the symptoms, but at the same time also addressing some of the factors which increase the risk, like substance use, and because that can be an issue in terms of self-medicating. Cannabis can help with anxiety, but at the same time can also trigger psychotic symptoms. So it's a risk factor, yes, that was well received. The study showed that it is effective. The problem with that is it's more demanding on the patient, so not everyone would commit to a couple of sessions, high intensity CBT addressing those issues. So the other option is medication, obviously, or a combination of psychological intervention and medication. Okay,
thanks. So what's your threshold for prescribing?
Yeah, it's interesting because you referred to Pat McGorry, and for the studies we're using an instrument. It's called CALMS, Comprehensive Assessment of at-Risk Mental State, which was developed in Melbourne, and is kind of a good clinical guide. It's very comprehensive, and we are working through this, developing a much easier to use version, what can be applied by GPs in a few minutes after seeing a client, just to assess the risk level. And it also defines a threshold where we say, okay, that's not at risk anymore, that's actually psychotic. And that would trigger, for instance, starting antipsychotic medication.
So let's assume that young person presents and we're fairly convinced that there are subtle signs of psychosis, so perhaps intermittent auditory hallucinations that are experienced as a true hallucination.
Yeah, there's sometimes the issue if you think about anxiety disorders, which can present with what we call dissociative symptoms, derealization symptoms, depersonalization symptoms, and sometimes the patient says, I can see maybe shades at the corner of my eye, this kind of thing. I'm very scared when I go home, it's dark. Yeah. Sometimes I see something in the bushes and so on. So that's not psychotic, it's hypervigilance. Yeah. And different to that, if a person is experiencing certain things half asleep, yeah, it's also not really psychotic. So we have to be aware that a person has to be fully alert, basically. Yeah. And then describing, let's say, when we're talking about hearing voices, so really describing this as a real voice. Yeah? So sometimes I ask the patient, is it almost like listening to the radio? Yeah? More subtle symptoms is just hearing the voice, and then it can become more severe in terms of intensity, and maybe several voices, so they can talk to each other. So all this is already indicating, some psychosis going on. I wouldn't go that far that this is sufficient for schizophrenia. There are other symptoms, obviously. There are other criteria, but that's more than handled by a specialist, psychiatrist in this case.
So really, making a diagnosis of psychosis is sufficient, and then perhaps seeking referral on to a psychiatrist.
I would say so, or hospital. If you're concerned about risk, so if a person is really, really struggling with simple things in life, and unfortunately what we know from our statistics is that suicide rate is quite high, coming with the condition. And particularly think about it as a young person, realising maybe something is wrong, and maybe it's a severe mental illness, then the paranoia, maybe command hallucinations, or a voice telling the person to jump off the cliff in front of a car or whatever. And then really this is a trigger, that needs to be hospital, and immediately, that's an emergency. And requires specialised assessment and care. But that's not how at-risk kids or young people present. It's more a bit vague. And as I said, the study indicated a lot of those are already on standard antidepressants to address certain issues. And as I said before, they fulfill criteria for major depressive disorder, anxiety disorder, and the medication is matching these kind of symptoms or diagnoses.
So if you are thinking about medication, are there certain medications that you feel are definitely first line?
Yeah, for the younger people, I think very common is trying risperidone. It's a common antipsychotic. Unfortunately, most of the antipsychotics can cause metabolic syndrome. So people can become pre-diabetic. Of course, the increased body weight, high blood pressure can rise. The whole combination of these kind of symptoms can be caused by most of the antipsychotics. But risperidone, 2 milligrams maybe a day as a starting dose, giving that for maybe 6 weeks and monitor. If you're not concerned about risk, I think that's important when as a GP to start antipsychotic treatment just without specialist backing. That will be a starting point. Very often what we see, and also the studies show that quetiapine or Seroquel is used quite frequently. Similar problems that can increase appetite. It's quite helpful with sleep, but a lot at a lower dose, so it's 25, 50 milligrams, sometimes 100. But it's probably not sufficient to treat psychotic symptoms, and risperidone is more effective in this respect. There are obviously other medications that can be used. Sometimes if you have a patient who's already overweight, you have concerns about further weight gain, maybe aripiprazole is an alternative drug. It is a little bit different how it works in the brain. I tell the patient take it in the morning because it can be activating.
Yeah.
I'm not a fan to combine aripiprazole with SSRIs. There's a little bit of an overlap. Side effects can occur, the common side effects with SSRIs. Headaches, feeling nauseous, or even becoming agitated. Talking about agitation, so some of the antipsychotics can cause side effects in terms of what we call akathisia, for instance, or something. It's a relapse of the psychosis, but it actually is a side effect of antipsychotics. It usually comes up after a few days or a week or two on the medication, and the patient is restless and pacing around, can't sit still, is clearly agitated. I think it's the best description of what we see there. That can be caused by the medications, antipsychotics.
So what do you do in that case?
Changing the antipsychotics.
Okay. Yeah.
And you can give very briefly Valium, for instance. That can be quite helpful to ease these kind of very unpleasant side effects. But usually with the new generation antipsychotics, the risks are a little bit lower compared to the first generation antipsychotics, which are hardly being used nowadays.
Yeah.
Again, 2 milligrams, sometimes 3 milligrams a day of risperidone. That's a good start.
And so would you start on 1.5 milligrams BD, or do you titrate the dose up?
I would start with the night dose, and probably depends if there are a lot of sleep issues. You can combine it temporarily with quetiapine or Seroquel. Maybe it depends. If a person not very heavy built, maybe 1 milligram, 1.5 for a week, just to ease in, and then titrate a little bit higher. Sometimes you get away with just a night dose. Sometimes you have to add a lower dose in the morning, but that should come a little bit later because can have sedative side effects as well. And you should monitor weight. That's, I think, also important.
Yeah. So what are your thoughts on co-prescribing metformin in the context of psychotropic-induced breakdown?
I have not made really good experience with this. Again, side effects, diarrhea, and I think it's not a perfect solution if you have these kind of side effects. It's more, maybe get a dietitian involved. Very often what you see is just junk food eating, a lot of sugar. People need to be educated about healthy eating options and how to deal with the urges. So it's a lot of snacking happening, and they're not really aware. They eat a lot. So I think if this is an emerging problem, a dietitian should be involved.
Okay. So if we turn our attention now to the notion of when to refer to a psychiatrist. There's obviously the emergency situation. As many of our viewers will be aware, there's the GP psychiatry support line, and they can actually ring and ask for advice on medication, which is very, very helpful. But if somebody has an emerging psychosis, or you have a suspicion that that's the case, would you recommend always that they see a psychiatrist?
Yes, I think so. If a certain threshold is, even when you think about starting an antipsychotic, I think it is safer to get at least input from a psychiatrist, and I think the psychiatrist wants to see the patient ideally, really assess the situation, and particularly the risk level, and also diagnostic clarifications around how the patient is presenting. Ideally, it should involve psychoeducation, involve a psychologist, ideally a clinical psychologist who has experience working with people with psychotic symptoms or even schizophrenia. I think another important issue is seeing what is available in the community and other services. So in Newcastle we have the STEPS program, specifically for young people experiencing their first episode of psychosis. And they can provide access to a psychiatrist, access to psychologist, access to occupational training, and they can individualize helping the person to recover from the first episode.
Yeah.
And they also provide a lot of psychoeducation, and it has to involve the family. We know that good family support is very important. Can involve the partner. You can imagine the partner might be really stressed out.
Certainly,
Things like this happen.
As you've mentioned, the impact of serious, significant mental health problems on a family are very significant. Yeah. So talk to me about your approach in terms of how you work with the family, what kind of recommendations you'd make.
I think it is important to understand that we have quite effective ways nowadays to help patients. That doesn't mean that we can do magic every time, but we can make a difference and keep this the rehabilitation process going. But very often I see after a year or so, even shorter periods, that the patient, I'm fine. I'm fine. So why should I take this medication? And then really, the psychoeducation kicks in and says, look, all the studies indicate, if you go off the medication too early, relapse is more likely. Doesn't guarantee, but from a safety point of view and the therapeutic point of view, be it at least 2 years on the medication. That's our guidelines. And what you can do is further down the track, of course, reducing the dose, and then monitor the patient on a regular basis, really making sure that psychosis is not coming back. A good patient can actually self-manage in a way that they say, okay, he knows, he's the expert, and mostly if it's done early, the success rate is much better. So we know also that the duration of untreated psychosis, the longer has an impact. The longer untreated has an impact on the prognosis. So we want to keep that as short as possible. That's the reason when we're talking about at-risk mental state, that would be ideal. To think about cancer first, little signs, high success rate, and a little bit the same what we see with severe mental illness, particularly schizophrenia. It's very similar.
And so thinking also about the environment and family, I remember there's that study from Vaughan and Leff, it's probably mid-70s, somewhere around there, I can't really remember, but looking at expressed emotion, so over-involved, critical environments where the personal space of the person isn't respected. And that study actually demonstrated that relapse rates were much higher when people were exposed to those sort of negative environments. And so that kind of family work, ensuring there's compliance, but also ensuring that the families aren't too intrusive. So getting that balance right is important.
Also understanding what that means, psychosis. I mean, we all know schizophrenia has a stigma. I prefer saying psychosis, not using the bad term schizophrenia, because psychosis is more neutral. It's part of the condition, schizophrenia, as we know. But giving parents or partners or friends, maybe sometimes a good friend is also involved, supporting a person with a condition. Some understanding how a person might feel when you think, let's say there are all cameras in this room, observing you, smiling now.
Well,
there are cameras in this room, observing us, but as an imagination. So, and then really convinced about that. And that's what we see then, or hearing the voices, my negative voice, running commentary about what the person is doing, or command hallucination, do this, do that, and whatever. And clearly also negative comments, what you do, and commenting that. That can also occur in other conditions, like severe depression, for instance. bipolar affective disorder can also present psychotic symptoms, either when they're manic or depressed, depending on what the mood situation is. Can be grandiose, the voice can really enhance the person, but can also say, you can fly, you can jump off the roof and fly. And same when they're depressed, very negative feelings of guilt and all that. So psychosis is not just schizophrenia, I want to say. But coming back to your question, expressed emotion, yes, I agree, but think about it also that way. The study was done in the 70s, so the arsenal when it comes to medication is a bit different, or 50 years ago. And then think about people with schizophrenia have difficult psychosis and have difficulties to, let's say, interpret gestures, facial expression of other people. So they also perceive this as threatening. Now imagine you are actually angry as a parent. That is just facilitating this. It makes it worse. And even a neutral face is already interpreted as threatening and negative and whatever. And that's very often what you see when you talk to people with a condition, that they really struggle with interpersonal stuff. And that also triggers then what we see as social withdrawal. Obviously, if you're not getting along with other people because you're puzzled, but that's what they're intending to tell me, or just signal me, and you always go to the negative side of interpretation. You better stay alone. So that's often what we see. And you're right, the study shows that if you're in the face of the patient, it's simply an overload, what they can't process in a way we process on a daily basis. And then another thing is, we know from other studies, they have less trouble to understand the smiling face, compared to all the other subtle expressed emotions. So treat a patient with schizophrenia always with a big smile.
So I'd like to move now on to the vexed question of an organic workup. So if a general practitioner were to refer somebody to a psychiatrist, what sort of workup would you like to see? What's absolutely necessary, and what are things that you could wait to a little bit later?
Going back to the beginning, when we see someone, what we consider, that could be a risk mental state. Obviously, what you do is just a general blood test. Thyroid function, vitamin levels, just a blood screen, just to see whether there's anything indicating, or we can easily rectify iron levels, can cause irritability, fatigue and all that. So it almost looks like a little depression sometimes, or even attention disorder in younger people. That's the basic. I would not go further at that point in time, once you have excluded that. And then also keep in mind substance use. Sometimes I think it's warranted to do a urine drug screen if you have suspicions and you can't really engage with the patient around these issues. Think about 40% of young people using drugs, mostly cannabis, but also MDMA or ecstasy. And we're living in a time where we have almost an epidemic of ice users, which is quite concerning, because these drugs can actually almost mimic schizophrenia, positive and negative symptoms, hallucinations, but also the lack of energy, volition, anhedonia, social withdrawal. What we see is, I think the urine drug screen can help. Now, when we're talking about more technical examinations or assessments, I think some people think, doing brain scan, CAT scan is a waste of money. When I did my training in Germany, every first episode psychotic patient got an MRI scan. I think there is some value in that, but you hardly find anything. I would say we should be more guided by doing a neurological examination on a patient. If there is something, there is something, then maybe even get a neurologist involved to follow that up. So imaging is standard imaging. It's not really telling you much about the condition. Another more recent issue is looking into the presence of antibodies against brain tissue in general. Mostly the receptors in the brain, because as you know, there's a blood-brain barrier. So the immune systems are separate, the brain and the periphery, the rest of the body. So if there are antibodies in the periphery, there was some leakage in this respect with the brain. So the body immune system had contact with the brain and produces antibodies. And that can actually look like schizophrenia. So because you have an inflammation process in the brain. Very often you see also organic symptoms coming up, epilepsy, some seizures, and it's getting worse. Obviously, if you find some, which is not very common, so some studies say 1% of patients with schizophrenia actually show a positive screen for autoimmune antibodies for GABA receptors or glutamatergic MDMA receptor antibodies. And this, of course, changes the treatment approach. So you have to get a specialist in place, getting some guidance around what is possible to treat an autoimmune disorder affecting the brain. Whether this is a cure, we don't know. But it gives you a different angle to how to approach that. But that's highly specialised stuff. And there's only, I think, one pathology service in the entire country providing the service.
Lastly, physical exam of the patient on antipsychotics.
You should look for extrapyramidal symptoms, EPS. That can mimic a little bit like what you see in Parkinson's disease. Simple tests are like rigidity in your joints, if you do this on a regular basis. And also see tremor can come up with the condition, but that's already when it's quite severe in terms of the effect the antipsychotic has. It's not very common with the new generation antipsychotics, but it can still occur, particularly at higher doses, and that needs to be monitored.
Okay. Well, thank you so much for your time. This has been a fabulous conversation, and I'm sure that people who've taken the time to sit and listen to what you've had to say, because we've moved through the early psychosis movement, the ultra high risk or the at-risk group, how to recognise symptoms of psychosis, some first-line recommendations in terms of medication, environment, treatment of the family and CBT and those sorts of things, but then also some of the kind of newer nuances in terms of potential immunological kind of risk factors for schizophrenia, which are very low incidence, I understand that, but it's still very interesting, Okay. Well, I hope you've enjoyed this conversation piece. As always, you can contact the GP Psychiatry Support Line if you are seeing a patient and you have questions in relation to medication.